Hello, everyone. Thanks for joining for this quick webinar. My name is Tyson Moore. I'm a nurse practitioner at Children's Mercy Hospital and Clinics in Kansas City, and I am also the ANNA SPN lead for the pediatric section. So feel free to always reach me on there if you have any questions, concerns, anything of that nature. But today I wanted to talk to you guys about immunosuppression. Hoping this will be kind of maybe a three-part series as I go forth. But today we're going to talk about immunosuppression, and this is from induction and to maintenance. So our learning objectives are going to be to just review some basic pathophysiology of rejection or the immune system process, how that would happen, as that is where some of the immunosuppressive meds work. And then we're going to identify some commonly prescribed medications and for induction and maintenance. And we're going to understand common side effects, the complications that can occur, and drug interactions that occur with immunosuppressive meds that we use, and then describe the mechanism of action for some of these immunosuppressive meds, just so you guys understand kind of where these medications work to prevent rejection. So our main goals of immunosuppression, and it doesn't matter pediatric or adult, but the goals are pretty standard. It's a balance, and it's a delicate balance. And we try to balance kind of three main things. So it's a balance of a triad where you want enough immunosuppression, but not enough to prevent infection, and not so much that you also cause toxicity to other organs. So we want to prevent that host immune response against the graft, which is the kidney, what we call when you put a kidney in and you connect it, it's called an allograft, the kidney allograft. So we want to prevent the body from attacking that. And then we want to prevent rejection on the same time, enough immunosuppression that you can prevent the body from attacking itself. Then you would prevent complications from immunodeficiency. So if you get too much immunosuppression, you can have more viral infections. You can actually have malignancies or cancer risk. You will have this one specific one called post-transplant lymphoproliferative disorder or disease. And then you can also have toxicities from the immunosuppressive medications if you have too high of a drug level in the body, which would cause injury to the kidney known as nephrotoxicity, hypertension or high blood pressure. You can have lipid disorders and also bone marrow suppression or myelosuppression. So like I said, it's a balancing act. And as you can see here on this little diagram, it's a scale. So you want enough immunosuppression to keep the graft alive, to keep the body from attacking it. But it's, at the same time, you're constantly balancing, well, I don't want to have too much because then I can get infection, toxicity where it's hurting the kidney itself, cancer risk, and you can actually have cardiovascular morbidity and mortality from long-term immunosuppression if your doses are too high. So this is what a little diagram I wanted to show you. So this is, and I'll walk you through it. Without immunosuppressive, how does the body or your immune system attack the graft? And it's a very complex process. We could literally have a webinar just on that. But in short, what happens is your kidneys, or your transplant kidney, has cells. And that little purple cell on the left would represent one of those. And so you have this thing called an antigen presenting cell, or APC for short. Well, you have these things called T cells. If you remember back to earlier nursing school, some of the pathophysiology, your T cells are always roaming around. And they come from your thymus is kind of where they're made. They can go to the lymph nodes, but they're constantly circulating around in your bloodstream looking for invaders. So the first one here is the CD4. And it's right after that, you can see after the APC, there's a CD4 cell, which is a T cell. That guy, there's two types of T cells. So there's CD4, which is your T helper cells. And I call those kind of the alerters, the ones that sound the alarm that something's going on. And once that T cell binds right here to the antigen presenting cell on this little protein complex, what we call major histocompatibility complex, and it's type 1 and type 2, but when it binds, this T cell becomes active. It's like, I've identified something. So then it shoots off a whole bunch of different processes, as you can see on these next steps. One thing that's released, and I'll show you some separate slides later, interleukin-2. And if you remember the interleukins, those are those cytokines that are released in kind of the inflammatory response of your body that then cause this other cell, CD8, or also known as, it's a CD8 or T cell, called natural killer cells. Those are your cytotoxic killer cells, and it will actually cause a cellular mediated toxicity. So it goes along this pathway to attack. So this is kind of what we would consider more of the cellular or cellular rejection pathway. That same messenger or alerting CD4 cell can go down another pathway, which it actually talks to the B cells. Your B cells are problematic because they produce antibodies, and then the antibodies can also attack the graft cells. So as you can see, there's kind of two different pathways as we go through these slides to think about a little bit on how your immune system can go about attacking the graft cells. There's two different pathways that we constantly have to worry about when we're using immunosuppression and prevent rejection. So I've drawn this little slide here too as maybe a little bit simpler one, but you have this antigen presenting cell. And again, you have these little, what look like little arrow shapes, because I couldn't pick a different one. I was trying to pick the right one, but that's what's that major histocompatibility complex. It's a receptor on those antigen presenting cells, and that TCR, it means T cell receptor. So all the CD4 cells have T cell receptors. That's what actually binds or locks on to that MHC molecule, and it starts the process. So as you can see, again, there's kind of two different pathways. It either goes and alerts kind of more this cellular route, which is the CD8 or cytotoxic killer cells, and they will go in and attack, specifically, you can see them on biopsy, the renal tubules. So you get tubulitis a lot with cellular rejections. And then you can go a different pathway, which is the B cells, and both can happen at the same time. But the B cell we worry a little bit more because it forms, and these antibodies can last for a long time. And we can do a panel and actually test and see how many antibodies the patient has. So once you get these antibodies, it's kind of a worse picture because they can hang around. But what you have is that B cell then binds to the graft antigens and recognizes them. Then that B cell turns into a plasma cell. The plasma cell is what releases the antibodies, which then attack, and you'll see it on a biopsy, the actual kidney blood vessels is where they deposit inside. So you'll actually have some vasculitis issues and deposits. These little plasma cells leave behind little fragments, and that's what you'll see on the biopsy. They're called CD4 cells or C4D cells. And you don't have to memorize that, but that's kind of what we're seeing on a biopsy to help us differentiate between the two types of rejection. This is a breakdown also. I took it from Wiseman, but I love it because it's a breakdown of how T cells activate B cells. And I want you to pay note to my little arrows. So as you can see, this little pink looking cell, this CD4 T cell on top, has receptors. There's a bunch of receptors on T cells, and all immunosuppressive medications usually try to target pathways or binding sites. So up here, I want you to note there's a CD8 binding protein complex. Then here again is our T cell receptor. Then there's this, again, major histocompatibility complex. And right here is kind of the initial one, but there's different messengers, as you can see, that we have to think about along on the T cell as well, that we have to work and try to treat. From there, you also have on the side of a B cell, these things called CD20 cells. And the one medication I will talk to you about later, I believe I have it on here, but we use it a lot, is Rituximab. And it's a B cell depleting medication. And it binds to CD20. Over here, I'm not going to go over to these. These are not commonly used medications, but you can see there's other receptors. And then down here as well, there's so many receptors on these cells, and we use medications to bind to those, like I said. Now, when these chains lock up here, there's a lot of processes you'll see later that go on in these cells, but what will eventually happen again is it turns into a plasma cell. And from the plasma cell, then you have to worry about antibodies and also the complement cascade that we're all in love with, this long complement cascade. And it forms essentially this thing called a MAC complex, which essentially how I describe it on other slides is it forms like a cylinder. Once all these proteins form, it performs they lock together and make a cylinder, and it jabs itself inside of your kidney tissue cells, and it will cause lysis of those. So it's very, very potent when that happens. And again, here is a slide of a T cell. So I'm kind of just going over the basic pathology and the physiology of this. But again, to reiterate, MHC, you have a TCR, you also have CD3 that we have to worry about, receptors, a CD4 receptor we have to worry about. And then over here again is your CD8. And over here, down here, you can see they've already put on this a few medications that work here. So there's a medication we'll talk about later. It's Bladder Sep. So Bladder Sep binds. It's a binding site for CD80, which is here, and it's also known as B7.1. There's two receptors, B7.1 and B7.2. And you can see over here in my right text, CD820 is a binding site for CD8 80 and CD8 86. So that's where Bladder Sep is going to bind on here on these blue cylinders to block the response of CD8. Excuse me. The main one I want you to note that you have to worry about is once all these receptors kick in, there's this thing called calcineurin. Calcineurin will actually cause the cell to, in the DNA of the nucleus, to undergo DNA replication and synthesis, but it releases, calcineurin helps release also interleukin-2. So all these there's a bunch of little processes inside the cell, but all these receptors activate the T cell. The end goal of a lot of T cells then is to either cause more T cells to be activated, and it also causes them what we call to proliferate or to produce. So that's how it kind of starts the process, and then it produces more and it produces more and it activates more and more T cells as more interleukin-2 is released from the cells. So that interleukin-2 is kind of the other messenger that goes out to the other T cells that says, let's get into gear. We got something to attack. And again, these are, as we go through our slides, I wanted to bring this one up because this is a slide, it's very busy, but it shows you all these little boxes show you all the different binding sites and stoppage sites of all the different immunosuppressive meds that we use. You have up here again is the antigen presenting cell, T cell receptors, your CD3, the MHC, CD8, so all these different receptors, right? Well, all these medications, as you can see, work differently, mainly to target T cells. You have cell cycle blockers, which gets inside and it blocks the DNA and RNA, which is Mycophenolate Morphephyl, or also known as Cellcep, and then azathioprine. You have Cellcep, which is one of our induction meds I'll tell you about. It's an interleukin-2 receptor blocker. Then you have Sirolimus, we'll go over later. It's an interleukin signaling blocker. And then Bladder Sep, again, it blocks the CD8 receptors, and it prevents another stimulatory blockade. This pathway likes to also cause more T cell proliferation. And then down here you have calcineurin inhibitors, which commonly you may be familiar with. These are your Cyclosporine and your Tachylimus. And then over here, some of these are kind of these T cell depleters. There are a lot of monoclonal type antibodies, polyclonal and monoclonal. So you have either Thymoglobulin, and then over here you may have a similar one, Rituximab. So like you said, very busy. We'll go through it. We'll try to break it down on each medication and where they interact. But I wanted to show you this because it's so complex. These medications are that we try to block the immune system, mainly targeting T cells by many different ways. So again, these are some of the basic immunosuppressive medications that we use. You have calcineurin inhibitors, cyclosporine and tacrolimus most commonly. You have CD binding site, which causes B cell depletion. So it's going to wipe out your B cells, commonly used for that type of antibody type rejection. Then you have interleukin-2 binding receptors used for induction, Cellcep. Interleukin-2 signaling inhibitors. So there's a binding inhibitor, and then there's one that blocks the signaling of interleukin-2, known as Sirolimus. Cell cycle blockers, which messes with the DNA and RNA replication, Mycophenolate Morphephyl and azathioprine. And then co-stimulatory blockers, also Bladder Sep. So these are some of the common ones we're going to talk about today. So the first thing we're going to do is induction therapy. What is induction therapy? Induction therapy is used right at the time or right before transplant. So you're getting ready to get your transplant, not days before, but like in getting ready to go to the operating room to get the kidney transplant. And we have to attack the body to prevent acute rejection. Acute rejection is something you never want. So we do a lot of stuff kind of ahead of time to give you wiped out immunosuppression so that you won't have immediate rejection. It does greatly reduce the risk of acute rejection. The therapeutic antibodies do provide potent immunosuppressive activity, and it can last sometimes between a week to 2 weeks after transplant. So we're constantly monitoring white blood cell counts and all cell line counts. Depending on the agent that you pick, you may have a delay that you might not need to start other nephrotoxic drugs like tacrolimus as soon, because you have that ongoing, as you can see, week-long immunosuppression going on. So you don't need to start them as soon and prevent nephrotoxicity to the kidney as early. And it allows for titration. So it gives us a little bit of kind of fluff time where we can titrate up our maintenance immunosuppression without having to kind of go gung-ho on them early, because we have that background immunosuppression from the induction therapy. So we're able to kind of staircase them up towards their maintenance goals, maintenance trough level goals on the maintenance medications. And that can take several days. The one problem with induction therapy is it is very expensive. You're in tens of thousands of dollars for some of these medications, but insurance does cover them. There are risks for significant side effects, and we'll go over one medication has a lot of side effects that can happen. The main one I get worried about with some of these drugs is hypotension or low blood pressure, especially in the OR, because it could cause kind of delayed graft function or shock to the kidney if it doesn't get enough blood flow from low blood pressure. You will have an increased potential for infection over a longer period of time because you have really potent immunosuppressive effects. There are the risk of development of antibodies against the induction agents. We have had that happen. So that's really troublesome then when you need to have those medications again, so you get exposed to them again. So if you have them, there's problematic if you require repeat exposure, such as like you need another transplant, or there's a bad rejection and you need to give thymoglobulin, but you have antibodies developed. So you're just you're higher risk of having adverse reactions. And then there may increase the risk of, which we'll talk about in a whole nother webinar, this thing called post-transplant lymphoproliferative disorder, because of the amount of immune suppression that's given. So there's two types for induction therapy. There's polyclonal and monoclonal. And they are depleting polyclonal antibodies. The most common one is thymoglobulin. And how they form this medication is they actually used a rabbit thymus to create the medication. And so that when it's in there, they actually pull it from and derive it from a rabbit, a little bunny. It's thymus, and that's where thymoglobulin comes from. There is another one, which is depleting monoclonal antibody, and I can't pronounce it other than Campath. I always mess it up, but we don't use that one as much. The one that I say we use the most commonly, unless it's your second transplant, is Cellcep or Simulect, because this is a non-depleting monoclonal antibody. It cannot delay, you cannot delay the initiation of your tachylimus or your calcineurin inhibitors with this. So you have to start it. You have to start your tachylimus IV with this. You can't wait like you can on the other ones to start your maintenance immunosuppressive therapy. And it is not a treatment. The Cellcep, we never use that one for treatment of rejection like we do thymoglobulin. So you can see here, there's many different monoclonal and binding sites. So right here, you'll have Cellcep on your T cell, and it attacks here on the CD25. And again, it will affect interleukin 2. So it gives you a good amount of immunosuppression because it prevents signaling and sometimes proliferation of the T cells, and it's potent. And then what you'll have down over here is used commonly this is a monoclonal antibody. And what we'll use here is a CD20 to deplete B cells if we have to. And then this one, which is commonly used, is called Equilizumab, commonly used for another disorder called atypical HUS. And it will actually bind to the complement system and prevent that little membrane attack complex I told you about earlier that forms that cylinder into the pipe. But again, the most common one is Cellcep for the immediate first transplant. Otherwise, you'll use thymoglobulin for your bad rejections or a second transplant, because you need even more potent immunosuppression for that. So thymoglobulin, again, is a polyclonal antibody, and it's preparation obtained again from rabbits immunized with the human thymus. So, well, that's where it's from. I didn't know that. I kind of thought it was interesting when I first learned that. The antibodies react with the lymphocyte surface antigens, also known as HLA. We can check HLA levels in the patient, which rapidly depletes the number of circulating T lymphocytes. It depletes them. It wipes them completely out. So you really need to check your CBCs and your WBC counts carefully, because you will put them in a state where they don't have immune defense and they won't get one for weeks. It causes apoptosis or destruction, lysis, blowing up, or shrinking down of the CD3, which is a type of T cell. So you can actually check CD3 levels, and you need to, while you're using thymoglobulin, to see if you have too much thymoglobulin or you need to give subsequent doses. Proliferation of newly formed lymphocytes is decreased, and it remains greatly impaired after you stop the therapy. So when I say this one I really worry about ongoing if you use it for like rejection and not just induction, but you put them at high risk the more they get of cancer. And that's the downturn bad thing that we worry about down the road is cancer development from using these potent immunosuppressives. In Children's Mercy, we do use it in kidney transplant for, like I said, high risk or highly sensitized. So they have a bunch of antibodies from the previous transplant, or they've gotten blood transfusions. And so they have a lot of antibodies forming around. So what's called the panel reactive antibody, we're able to test for that. Patients that have high antibody loads in their body, we use it. It's good for those patients to prevent acute rejection. And you will need to use steroid withdrawal, or you can use it with steroid withdrawal regimens. So if you're using high dose steroids and you're using thymoglobulin, it provides that extra protection while you're withdrawing off steroids. You do have treatment for moderate to severe, or also kind of what we call refractory recurring acute cellular rejections, mixed with kind of an antibody mediated. But I would say if you ever think of thymoglobulin, it's a cellular rejection type medication, and it's used to prevent acute cellular rejection at the time of transplant. Here for the nurses, you can put on my slides, I believe, or it'll be on Anna's website, posted in the library later. I wanted to provide you with this because sometimes you need about dosing. This is our dosing that we use at our institution. So it's 1.5 milligram per kilogram per dose. But the dosage then for subsequent doses is based on how do they tolerate the first one? Have they had previous thymoglobulin infusions in the past? And what are you using it for? You do need to look again at your white blood cell count, or WBCs, excuse me, and platelets. And this is essentially what you'll kind of titrate your dose. So if you have a WBC count less than 3,000 or a platelet less than that, you'll decrease the dose by 50%. If you have a white blood cell count and they're severely neutropenic or a platelet less than 50, then you probably will hold a dose for a while. You consider decreasing your maintenance Cellcep doses to prevent severe bone marrow suppression while you're using this. So when we give the thymoglobulin, you'll see us back off on Cellcep, which we'll talk about later. Otherwise, you have too much. This is that risk I talk about, way too much immunosuppression on board. And essentially, you can impair their bone marrow where it doesn't want to come back, and they really won't have an immune response again. Their bone marrow kind of goes so suppressed that it just won't kick in very well for a long period of time, and your patient is at severe risk for infection. We do have to pre-medicate because of the side effects with Benadryl, Tylenol, and usually methylprednisolone. And it decreases the risk of cytokine release, or it can have a decreased risk of cytokine release syndrome, which is severe, can cause severe hypotension from this syndrome. So that's why you need to pre-med your patient. So if your doctor's ever trying to use this and they don't pre-med them, please let them know they need to pre-med their patient, because you do not want to have severe adverse drug reactions. Here are some of the common reactions. I have seen a lot of these reactions before. The ones that I worry most about, they will have this flash pulmonary, almost anaphylactic type picture. So they can get edema of the lips, the eyelids. They will get low blood pressure. So essentially they kind of go into like an anaphylactic shock picture. And then common, just during the transfusion, they get almost like they seem like bacteremia. They get a fever, they start chilling, they might get GI disturbance, vomiting, headaches, and shortness of breath. So these are on there just as a FYI to you guys. If your doctors are ever using this, just be aware of these side effects. It can happen. I've seen it, and it's scary when it does happen. Here's how you actually administer the thymoglobulin. So it is a 60-minute infusion after the steroid pre-medication, which is given 30 minutes before the start of thymoglobulin. And you want to give that first dose really over 10 hours, but you can give the other ones a little bit faster as long as they tolerate it. And if you give big doses, because of the patient's side, give it large doses over a really long time. Sometimes even do it over a day, or split it up and do it over 2 days. Some of that has to do with the stability of the med. You can't go past 24 hours, but or if your patient's had a reaction in the past, I would probably go really slow on the infusion time, just so that they don't have a reaction again. You have to have a central line. I know they say you shouldn't, or there's ways to get around it. If you look at the literature, but really we always place PICCs or have a central line to give this. So there's a thing down there. I'm not going to go into it too much. There is a way, if you need to use a PIV, what you should do with heparin and hydrocortisone, but it's a last resort if they have no other vascular access or you can't get one central line in. So what we'll do again, if you have a treatment infusion related reaction, you need to turn it off or go really slow, slow down your rate substantially, at least by 50%. If it's mild symptoms, you sometimes can give them PRN medications, slow down the dose and they do fine. Symptomatic treatment though, you're again, make sure you have these on hand. You're gonna need your Benadryl. You probably wanna make sure they have an EpiPen just in case. And then you can restart the fusion at a slower rate once they subside. Again, unless there's a life-threatening anaphylactic type picture that I talked about. Now, let me look real quick to see if I have any questions so far. I have one. No, just a welcome. Okay, so you guys can feel free to shoot me questions as we go along. I'll answer them in real time as I look at those. But Cellcep, again, also known as Simulect, it's chimeric, which means it's 75% human and 25% mouse. So same thing with thymoglobulin. It comes from the thymus, human thymus injected into a mouse, and they are able to essentially form the med and extract the med from there. It's the antibody that they're wanting. You do give a single dose at the time of transplant, and then the one with this one, unlike thymoglobulin for transplant, like when you're first getting it, so the time of transplant is you do have to give a secondary dose. So that's the difference between thymoglobulin and Cellcep. There is a post-op day 4. You need another dose of Cellcep. Thymoglobulin at the time of transplant, you only need one. You can see there's weight-based dosing, whether you're less than 35 or you're greater than 35. And then you need to look, because you'll have interleukin-2 suppression, and you'll have that probably buys you time to about almost a month. So very good at blocking interleukin-2, which again signals and activates the other T cells. So you will have T cell inhibition, but not depletion. So you're not going to wipe it out like thymo. You're just going to prevent it from being active and proliferating or recruiting and forming more T cells, versus thymo wipes them out. You don't have them and has severe bone marrow suppression. Has well tolerated adverse drug reaction or interaction profiles. So we commonly use it. Most common side effect I see a lot of times is low blood pressure in the OR, but sometimes it's hard to know, is that from the surgery? Is that from something else, the anesthesia, or is that from our med? So depleting versus non-depleting, like I was just kind of describing, depleting is thymo. You don't need to give your calcineurin inhibitors right away. They have a bunch of side effects, and then you have a huge risk or higher risk for over immunosuppression, which again, infection risk with your viral infections that you can get from the community, cytomegalovirus, Epstein virus, and then BK virus, which, like again, we'll talk in a whole different nice PowerPoint later on in a few months. And then you have cancer risk or other toxicities. Cellcep is a non-depleting, so you won't wipe them out. You're just kind of putting them to sleep for a little bit. You have to start your CNIs right away. Rare, you don't have that many side effects, and then you don't need as much immunosuppression, or you don't have as much immunosuppression right away, so you don't have over immunosuppression at the time of transplant. Any questions on our brief, let me go here, induction therapy so far? So remember, induction is at the time of or right before transplant. So once they get their transplant, then let's talk about maintenance immunosuppression. So this one's been around forever, commonly used and is a long-term maintenance medication, is prednisone. Its effects are not specific like some of the other immunosuppressive meds. It's multifactorial. So it does block lymphocyte proliferation through the inhibition of interleukin-1 and interleukin-6. So it's really good in inflammation. As you know, we use it for other things other than immunosuppressive therapy for transplant. We try to calm down the inflammatory response. It blocks, I forget, it's NKF beta, I forget, it's something factor beta, I forget the actual name, and activator protein 1, which is a transcription factor inside the T cell. It decreases synthesis in many inflammatory, so it's really good on cytokine inhibition and interleukin inhibitions. So like I said, we use it for a lot of inflammatory issues other than just transplant. It increases lymphocyte apoptosis or programmed cell death. And it also has a lot of anti-inflammatory, but it does not affect your B cells. So remember that. This is mainly a T cell medication. It does nothing really for your antibody producing B cell or plasma cells. The good thing about cortical steroids is you can convert to oral prednisone or prednisolone when the patient is tolerating the oral intake immediately post-transplant. So as soon as that patient's able to, if they're not a little baby with a G2 or something, which you can still use, once their bowels are working or they're up eating and drinking and their bowels are working, you can start it right away. So your single daily dose is taken in the morning with food. And the reason for that is to minimize the gastric irritation, and it prevents insomnia, or two common side effects with steroids. So you can get ulcers from using long-term steroids. A lot of our patients have to go on either a PPI, proton pump inhibitor, or H2 blocker like Zantac to prevent irritation to the stomach. You do need to reschedule your doses accordingly as soon as possible post-op. So what that means is if you got some before transplant, like your prednisone, you need to get on a schedule right away, a taper schedule, about kind of like probably post-op day 3 or 4 when they're able to take it by mouth. You do not need to give a subsequent dose when you're utilizing it for the thymoglobulin. Remember, we pre-med thymoglobulin with the methylprednisolone. So if you give that for the thymoglobulin, then really you don't need to give another dose of prednisone or anything like that immediately post-op, because you have the coverage. High dose steroids may make the blood pressure management harder to manage. It can cause hypertension. It causes weight gain, dyslipidemia, and the worst one is adrenal insufficiency. So that's why we always taper prednisone. Never just immediately go from 60 to 0. And most of them will end up on a chronic dose of 5 milligrams for most adolescents, and then somewhere like maybe 3 to 5 milligrams for the younger child to infant. I do know that it tastes really bad to patients. They hate the taste of it. So that will be something as a nurse that you'll need to know to try to help them work through how to get it if they have to take it orally. The next class of medications is, let me make sure there's any questions real quick. Oop, back up here. Chat, nothing in the chat. Okay. Is anti-proliferative agents. So this causes reversible inhibition of azonosine monophosphonate dehydrogenase. So for short, IMPDH. So this results in inhibition of the de novo pathway of guanine nucleotide synthesis and DNA replication. I also say it blocks proliferation inside the cell via blocking DNA or RNA replication. It is highly specific, which is nice for T and B lymphocytes. So we do, these are kind of the ones that are go-to for really making sure the patient doesn't have rejection. Probably more important, honestly, than tachylimus. It helps inhibit the salvage pathway, which is nice. So what does that mean? So these T and B cells, once they're kind of destroyed or there's fragments, your body, your immune system and other body systems try to salvage those little nucleotide breakdowns from the DNA, salvage them and use them right away. So it also blocks that pathway too, so that they also not only blocking inside the cells DNA and RNA, but it also kind of slows down or blocks any of those little nucleotides floating around from the T and B cells that were destroyed, so that your body can't salvage those and immediately form another response. It's useful for prevention of rejection, a very important one, and it can also cause reversal of ongoing rejection. The common one that you'll see us use is Mycophenolate Morphephyl. There's another agent called Myfortic, and that's for patients that have severe, terrible GI issues with Cellcep itself. Cellcep is the brand name. There's different size capsules you can see, so we can kind of vary our doses. And then there's a compound that we use. It's a liquid compound that our pharmacy has, and probably a lot of yours can compound it the same way for those ones that need the liquid version. And then the solid dosage forms should not be split, opened or crushed. Absolutely not. And we'll tell you why. And you got to handle this with care. So if they can't pill swallow, they got to go with a liquid. Azathioprine or Imuran is another one, anti-proliferative agent that we use, and it comes in 50 milligram tabs or again, another suspension. So with mycophenolate morphephyl, you really need to take it with food to help decrease the GI side effects. That's the most common thing you're going to hear from your patient is GI upset or GI distress or massive diarrhea or nausea, vomiting. And it may not start right away. This could be later. They've been on it for a while and they start developing this. You might think about Cellcep and really kind of seeing what dose they're on and when the symptoms started to see, is it gastritis, rule out infection, think about Cellcep. It decreases the rate, but not the extent of absorption when you take it with food, so we really don't care. The possible adverse drug reactions, though, with Cellcep, again, is GI upset, diarrhea, very common. Bone marrow related, though, it causes leukopenia, thrombocytopenia, and then you have a really high susceptibility for infections with this medication because, like I said, it's potent, but it's great because it works. And then in rare cases, you can get photosensitivity. You do not want to administer these, so take note if your patients are on this. You do not want to administer these with calcium, magnesium, aluminum, any iron or zinc, or if your patients are still taking Renvela as a phosphite binder, or you have some patients who are long post-transplant and their kidney function is starting to decline, maybe to CKD 3 to 4, and some of their phosphates going out of whack, but they still have their transplant and your doctor started them on Renvela. Just make sure that you have separated times with those medications in regards to immunosuppression because they bind to them. And then avoid handling this. This is very important. Avoid handling Cellcep. A lot of people have to use gloves with this, especially the pregnant people, because it is pregnancy category D. It causes teratogenic effects. Again, mycophenolate, when we immediately, at the time of transplant, we give a dose, IV dose of it, because obviously they're NPO for their surgery, and it's given over 2 hours. And then again, we'll give another dose immediately post-op to attempt to order that ongoing doses at kind of reasonable times. And why I say that, you kind of want to time it to maybe when they might take it at home. So that when you switch to the oral, you're getting good area under the curve around the clock. And I'll show you what I'm talking about, area under the curve, because that's how we manage this medication. So when you're giving an IV, talk to the doctors about trying to time it maybe about the time that they might actually take oral meds, whether it's 8 and 8, 7 and 7, so that they can get it accordingly to when they would do the oral version. You do want to transition to the oral version, though, once they're tolerating oral intake. And that's why we want the IV timed accordingly when they're going to take the oral at home. So our patients usually, like I said, immediately when they're eating, we start it. When their bowels are working, we start it. And you can see they are equivalent. So that's why I said get the IV on a PO schedule, because then when you go to PO, you don't have to do a lot of rearranging. The dose equivalent, so if your guys are going from Cellcep and you have a lot of distress and you need to go to Myfortic, it is another great agent. Works exactly the same way, less GI distress. If you have a lot of GI distress, your doctor says we need to put them on Myfortic, here is your dose equivalent. So 180 milligrams of Myfortic equals 250 of Cellcep. So that'll just help you have that information when you need to talk to your docs about what that equivalent looks like. So here's our guidelines and I'm not going to read through every one of these, but this is our protocol for using Cellcep at the time of transplant or induction. So if you need this information, it'll be on this slide for later if you need to reference it. And you can see the difference between whether you're using Cellcep, Thymo, or if you have cyclosporine-based regimens, which do require higher dosing of Cellcep than when you're using other agents. You do have pharmacokinetic monitoring, and this is what I was talking about, your AUC. So it's the area under the curve, so that we literally do time dosing. Your goal AUC needs to be between 30 and 60. Anything less than 30, you have risk for rejection. Anything higher than 60, risk for infection, risk for bone marrow suppression. And people say, well, is a higher AUC likely to cause GI distress than a lower AUC? I don't see that as a true relationship versus just the drug itself. So lowering the dose on Cellcep doesn't always mean they're going to get less GI side effects. Usually they're just not tolerating the drug itself, regardless of the dose. But we'll draw these levels at different time intervals. So you have a 0, which is trough, And then at 1 hour, 2 hour, and 4 hours, and then our lovely pharmacist helps us convert and figure out what the AUC is. We adjust the dose equivalent to make it fit within that goal. And you must have received 4 consecutive doses if you're transitioning from IV to oral before you do Cellcep kinetics. So like if we make a Cellcep change, you don't want to immediately do AUC. You need to wait a few days, make sure they have a couple of days of dosing before you would then get an AUC. Again, this has a REMS, okay? So all providers that prescribe this have to complete the REMS, and you should be providing this information to your patients. It's our standard at Children's Mercy to make sure the patients are aware that it is a pregnancy category D. It can cause teratogenic and congenital malformations or miscarriage. So a lot of education you'll have to go over when you're prescribing this or when your patients are using this medication, that you need to make sure you do good nursing education so they understand the risk. Azathioprine or Imuran, it's a purine analog, which means it's a purine equivalent, which is also a prodrug. So prodrug is not like active drug, it has to like actually convert and go through metabolism, but it does convert into 6 mercaptoprene, make sure I say that right, or 6-MP, okay? And that's important because once metabolized also, it converts into the active forms of 6 mercaptoprene, 6 thiazinic acid, and 6 thioguanine. These are all what it can convert into these active forms are. And that's all important because these purines are used in DNA and RNA replication and synthesis. So 6-MP works as a little metabolite, whichever of the 3, in the T cell, and it stops the cellular DNA process. So it blocks and inhibits DNA and RNA synthesis, which then in turn, when you stop that, results in a reduction of T cell kind of replication or proliferation. So it blocks more T cells from developing. 6-MP, though, you should note, is metabolized by 2 major pathways. This information, as you can see, comes from Enderby and Keller. And this is what I really want the nurses to take away from azathioprine, is it's metabolized by 2 pathways, okay? One of which is the thiopurine S methyltransferase, or TPMT. And that is a big acronym you need to remember. Since TMP activity is controlled by these genetic polymorphisms, what happens is you need to draw a TMP level on a patient to identify patients who are at higher risk of developing the toxicity that can happen from azathioprine. So what happens is you need to draw, before you ever start or switch to azathioprine, you need to get a TPMT level on your patient. And the reason for that is patients who have a TPMT deficiency have a great risk of myelosuppression, bleeding, infection, and death. And when you have increased levels of cytotoxic levels of that 6 thioguanine nucleotides inside the red blood cells, it will actually cause a lot of dyscharias, red blood cells. So it really messes up your bone marrow, and it can cause death. It's useful in maintenance immunosuppression, but it is definitely not first line compared to Cellcep or Myfortic. The nice thing about it, though, is those patients that just can't tolerate either one of Cellcep or Myfortic for whatever reason, and they're just not doing well on that form, then you can switch them to azathioprine, given you did what I said and checked that level of TPMT, because it has fewer GI side effects. And so that's usually why we switch the patients to this medication. Other advantage is it only requires a morning daily dosing. It's not every 12 hours. So sometimes patients do like that because they don't have to take another one of them in the evening. With all immunosuppressions, just like this one, you still have the risk of leukopenia or low white blood cells, low platelets, anemia. So it's all that bone marrow stuff, over suppression. You actually can get pancreatitis. Haven't seen it, but haven't seen it in case reports. The thing I worry about azathioprine is hepatotoxicity, so be checking your liver function test. And then you actually can get alopecia or hair loss from this, and it's more frequent in the Asian population for some reason. Again, remember, purine, azathioprine, think purine. So be cautious, because sometimes patients are on allopurinol. The effects, when you have those both combined together, greatly enhanced. They're greatly enhanced when you have a combination of azathioprine and allopurinol. It can increase the levels of 6. Remember, there's 3 different metabolites. This one increases the levels of 6 mercaptoprene mercaptopurine, and that can lead to like fatal blood dyscurias or severe myelosuppression on your bone marrow, where it sometimes has a hard time recovering. So just don't put the two together. And if you see a patient on allopurinol or azathioprine together, or somebody's talking about it, say no, and talk to them about this drug interaction. You need to monitor your CBCs closely, like with all, but specifically with this as well, because of the risk of bone marrow suppression. Let me look quick, see if I have a question. Nope, not yet. All right, so inside that T cell, we talked about a lot, right? Here we go. Over here, we talked about our kind of our cell cycle blockers with the DNA and RNA blocking that purine synthesis. So you have over here, you can see azathioprine and Cellcep or mycophenolate, they block cell cycle, right? Your steroids are going to block nuclear factor kappa beta. Like I said, I couldn't remember the name earlier, but this is the kind of inflammatory mediator, the interleukin producer once you get up to this part of the cell. So it blocks kind of more generalized and not specific. Then you have other medications, sirolimus, which we'll talk about as an Mtor inhibitor. Down here, again, Cellcep, interleukin 2 receptor blocker. And I think that was it on this, but this just shows you at the end point would be that all of them try to get to that nucleus inside that cell, inside of forming that DNA proliferation, replication, and interleukin production. Oops, got to go down here. So what are immunophilin binding drugs? These are your tachylimus and your cyclosporine. So immunophilins are binding sites for these immunosuppressive agents or drugs with the T cells, such as cyclosporine, which is like cyclosporine binding site inside the T cell, and then tachylimus has a FK binding protein site. So tachylimus's drug name was FK506. So tachylimus binds to this immunophilin FKB. So that's how they work inside the cell. That's what they're trying to bind to. So calcineurin inhibitors, tachylimus, also known as Prograf. We have longer acting forms, Astrograf and Barcis, and there's, a bunch of generics. But again, enter your long acting as kind of common sense are not one-to-one interchangeable with the immediate ones. So if you're going to go use a longer acting one, you can't just put them on the same dose. There's a whole different dosing schedule when you're using long acting ones. Cyclosporine, also known as Sandimmune, Neurol, or Gengraf, probably the most common ones you'll see. I think everybody just gets the generic because it's cheap. And then also you have Mtor inhibitors, which you saw the sirolimus, which is inside or rapamune inside the cell as well. And Mtor is an immunophilin. So tachylimus is it's macrolide. It's actually macrolide antibiotic that binds to FK binding protein to inhibit the calcineurin phosphatase, and you saw it inside the cell. Calcineurin then helps the proliferation. So what tachylimus does is it results in the inhibition of that production and secretion of interleukin 2 and other cytokines inside that T helper or CD4 cell. It blocks or inhibits calcineurin with greater potency than cyclosporine. So that's why we use tachylimus over cyclosporine a lot of times. Just you have better outcomes. It's a little more potent on its effects. And both drugs, though, all of them are metabolized. All of these in these category are metabolized by the CYP3A4 and CYP3A5 system. So there's lots of drug interactions and food interactions when you're using these. So again, big one, avoid grapefruit juice due to that CYP3A4. You would not believe the amount of beverages that have hidden grapefruit juice in it. So when you're seeing elevated tachylimus trough levels, before you make a dose change, before you do anything, start reviewing their diet. Most likely they've drank some weird drink they saw at a gas station, or somebody gave them a drink of something else, or they started eating another food, trying to be healthy, and it has some byproduct or some combination of grapefruit within it. We do not use NSAIDs or pseudoephedrine, mainly because it can add to the nephrotoxicity that tachylimus can have on the kidney. If you have to, you have to, but we try to avoid those. And it can also cause hypertension when you use pseudoephedrine in tandem with tachylimus. Your drug side effects, which are very common. You'll have higher blood pressures, especially when you're having higher trough levels of tacrolimus. You can have hyperglycemia. I've seen this in the Black population. I've had two Black patients that have developed diabetes insipidus from tacrolimus because it messes with their blood sugar so bad. It can cause high potassium levels. So if you have a patient with lower stages of chronic or lower stages of kidney function, a long-term transplant patient, maybe CKD 3 or 4, and it's starting to have hyperkalemia, you might look at your Prograph. Lipid disorders, low magnesium levels in the blood, so you need to check a mag level with all these patients that are on this medication. And then what I've seen a lot of is a hand trimmer, just this really fine hand trimmer, and sometimes even lowering the dose doesn't happen. So you need to we put them on propranolol sometimes to help with that. But they do have this this little fine hand trimmer that they'll develop on higher doses sometimes. And then a lot of neurologic side effects or hair thinning. This is actually taken from our protocol directly, so no reference there because we developed this one and just put it into a table. So I just pulled it straight from that. So your initial dose you can see there, and then you'll adjust your doses based on trough levels. And as the table says there, I'm not going to read it, but you can see there's different trough levels based on how far out you are from transplant. And then you will need every 12-hour dosing for this, and it is not forgiving. It must be every 12 hours. And so compliance is a big deal when you have these every 12-hour medications. And you have different forms. You have a liquid suspension, so you have different options because you will have to up and down your doses to get in with your goal trough levels. So here's your IV to PO conversion. So if you have to get an IV TAC at some point, whether NPO or at time of induction, you're using tacrolimus because you use Cellcep, then you'll go with kind of this IV to PO conversion. You can see what it would be going from IV, and then you're like, oh, they're eating, we need to convert them over. There's your conversion. And then PO to sublingual, which we hardly ever use or don't use. And then you have other IV formulations. I'm not going to go a lot about it other than just be careful, like little nursing tips, like it adheres to tubing. So you can't really draw any drug levels from the line you're using if you're giving it through there. So you would actually need a separate line if you're drawing for that. So you really don't want to be drawing your trough levels from the line you're giving the actual medication through because it binds to it. And then if you're on TPN, you must be albumin free, as albumin will bind to the tacrolimus. Cyclosporine, a cyclic polypeptide, it binds to that, again, cyclophilins that inhibit the same thing, calcineurin phosphatase. It results again in inhibition and production. So it doesn't let proliferation or secretion of interleukin-2 or other cytokines. It's metabolized again. This one is just like tacrolimus to CYP3A4 within the liver. So whether you're on either one, got to worry about those drug interactions and food interactions. It is used as a second line agent. Really, it's kind of like it was around first. It's an older drug, but it's not used as much by our population unless there's a high risk for immediate transplant, like disease occurrence or reoccurrence. So patients with focal segmental glomerular sclerosis or FSGS, and they have bad proteinuria or bad nephrotic syndrome, you may see us put them on this first because cyclosporine has been a little bit superior to tacrolimus for that specific condition and having that chance of reoccurrence immediately post-transplant. These brand name products do not have interchangeable, they're not interchangeable. So if you're on the dose of one, you can't you can't just put them on the same dose of a different one. It would be a different dose between these different ones. So just keep that in mind. You can't just go straight one-to-one, go from new oral to gin graft. You can't do that. There's different strength tablets and different dosing for each one of those. You will be on a trough level somewhere between 250 and 350 for new transplants. I usually see them somewhere post long-term out between 200 and 400. And then you'll have, again, every 12-hour dosing. We really hardly ever use Q8 dosing, whether it's TAC or cyclosporine, due to the nephrotoxicity. Here's your PO to IV conversion if you need it. And concaminant, I can't ever say that word, but if you're using it together, MF dose must be dose adjusted accordingly. If you're going from cyclosporine to tacrolimus, because why do I say that? Tacrolimus again has more potency, so you may have to modify your Cellcep dose if you're going from TAC to cyclosporine. to actually give them more Cellcep because cyclosporine is not as potent. The longer acting ones again are Astigraph. So this was the first long acting drug formulation of tachylimus. It's only approved technically for adult kidney transplant recipients. I only use it in the adolescents. I don't think of any of the infants or toddlers or anybody like that I've ever used this on. It does have a black box warning in liver transplant because it had increased risk of death in females. So yeah, just be careful with it. But I haven't really seen any side effects from Astigraph or any issues. The only thing I would tell you is for whatever reason, they had more rejection on it than they did on the intermediate reacting. It has to be taken on an empty stomach. So, and it's in the morning. And so no matter which long acting agent you're going to use, it has to be in the morning and it has to be on an empty stomach. Otherwise you don't get as much drug exposure. As you can see, there's a 10 to 35% lower exposure when you give it 1 hour before, less than 1 hour before, or less than 2 hours after meals. So these are your dosing forms, but the main takeaway from Astigraph a lot of times is just in the morning, empty stomach, and it can't be the same immediate reloads. Like if you're going from TAC to Envarsus, you can't just do a straight over dose equivalent change. There's actually different dosing for it. Envarsus, this was it's actually really good in the Black and Asian population. I have used it on white males. I have one white male that is on it right now. It's the newer long-acting one. We like it better. We prefer it better, but sometimes insurance doesn't want to approve it. Again, it was approved in adults first. And it is newer and novel technology. So the tachylimus molecule is broken down into nanocrystals, and it's kind of sprayed into that tablet matrix to make it. It increases, by doing that, increases the bioavailability within the body. So you get more availability of the actual drug inside the patient, which decreases their Cmax. So essentially what you do is you have a comparable peak point for the AUC as you would with immediate. So it really mimics a nice version of the intermediate acting ones as far as like sustained drug exposure, which is better because we don't have as much rejection on Varsus than we do maybe Astigraph. They don't have as much variability in their pharmacokinetics like Astigraph does. So like absorption, distribution in the body, all those PK kinetics are a lot better than Astigraph. So we prefer Envarsus over Astigraph. And then you can see the available dosages down there. And this, I thought I had this slide up higher, but this is what I was looking for. But again, this is some stuff you need to keep in mind for cyclosporine. I already talked about the grapefruit juice, but you want to keep, it has a nasty smell. It really smells like rotten eggs. So if you put it in there with other tablets in a pill box, it can make them all smell like rotten eggs. So if you're using them in especially a blister pack, kind of a pill pack, some of our patients use that, you really need to like open it and set it away because it stinks. Otherwise they'll get very nauseated from the smell. It's very sulfur smelling. Not going to go over it again. The main ones, the difference though between TAC and cyclosporine is down here. It's gingival hyperplasia. You can still get a hand trimmer, and you will actually have hair growth, hirsutism. So patients start getting, just like they would on minoxidil, all this body hair everywhere. So for females, sometimes males with females, that's not very appealing if you're thinking about body image, to put female patients on cyclosporine because they'll start getting hair everywhere. And that's a big body image reason why they don't want to take this medication and their adherence is poor. Sirolimus is that Mtor inhibitor I talked to you about. So it binds to actually that FKBP12, but it's essentially that forms this, what's the actual Mtor complex is mammalian target of rapamycin. So Mtor is the complex that's formed when the drug binds to FKB12. So in the body or inside the T cell, you have sirolimus, the drug, FKB12, boom, binds. That complex is called mammalian target of rapamycin, or Mtor for short. The inhibition of Mtor suppresses the cytokine-mediated T cell, again, proliferation or replication, and it messes up that cell cycle so it can't release the interleukins again. It's metabolized by the P-glycoprotein and CYP3A4. So again, like tachylimus and cyclosporine, drug interactions from food and meds. So if I'm kind of going on a repetitive thing, always be thinking about drug interactions when you have immunosuppressive medications, because you're likely to have them and it can be very challenging. You can use this in monotherapy. Our liver transplants are just on sirolimus. They're on nothing else other than sirolimus. Or sometimes when you're, for patients who don't tolerate higher doses of the calcineurin inhibitors, you can actually use them together, kind of like a co-therapy for those patients that can't tolerate higher trough levels. You do adjust it based on trough, just like you do the tachylimus and cyclosporine. This is just for a presentation I gave at our hospital when ours runs the actual assays. Avoid grapefruit juice, again, same old. The main one with this one, again, sirolimus. Be thinking about that liver, checking LFTs with sirolimus, and then look in your patient's mouths. I've had a lot of patients get ulcers inside their mouths, and then they're nasty, like canker sores all over their mouths, which is terrible, because then they don't want to drink their fluids they need for transplant. They stop eating. They don't want to take their medicines. So always be checking in your transplant patient's mouths, because sometimes they have things that they won't tell you about, and they can have mouth sores, and those mouth sores can get infected because they're immunosuppressed. And the other one, sorry, is that I want to highlight on is delayed wound healing. I actually have a liver transplant patient who gets dialysis, and when he uses his fistula, he doesn't scab over very well. It's like a jelly scab. He doesn't really scab very well over his where his needle sites are. So it's kind of interesting. I have seen it in person, the delayed wound healing. Now, Bladder Sep is the one I was talking to you about. It's a newer kind of drug. It's an IV infusion, Nulogix, and it's selective T. It's a co-stimulation blocker. So again, if you remember way back to that one of those first slides, you have that CD28 on the T cell. So it binds actually to CD80 and CD86 receptors on that antigen presenting cell, or APC, and it causes the inhibition of CD8, which is on the T cell. So it blocks, it binds to the receptors on the antigen actually, and blocks it from binding to the T cell to cause an interaction, which then makes this T cell activated. So it blocks T cell activation, which is nice. It's used in combination with induction therapy, but I honestly never see us use it for induction. I always see it used for those patients that have poor adherence to the oral medications or have had rejections and they're just not taking their oral meds. We'll give them and schedule them for IV Bladder Sep. It's not first line for us, at least at our institution. We use it mainly for patients who have poor adherence and we have rejections and they're not taking the oral stuff. We got to give them something. So we've had good luck with Bladder Sep. The main thing with Bladder Sep that you need to know is always you have to check and screen your patients for Epstein-Barr virus seronegativity. So they have to be Epstein-Barr virus positive to receive this medication. They cannot have EBV negativity. There is an increased rates of post-transplant lymphoproliferative disease in those patients who are EBV seronegative. So you don't want that. PTLD is essentially a cancer that is formed in transplant patients. So EBV negative patients, you cannot get Bladder Sep. And we do have a PK study on Bladder Sep for pediatrics currently going on right now. Not us, but nationally. So you can start at immediate post-transplant if that's the one you want to choose. And you can see, like I said, we use it maybe for those non-adherent patients, but regardless, your initial dose is going to be 10 mg per kg. And then what we'll do is we'll kind of titrate, or sorry, this is for the induction. What I was going to say is if you're converting from a CNI for adherence, that's where I got myself messed up here. But if you're going from CNI, from another oral agent or a calcineurin inhibitor, you'll take them off of that and you'll put them on Bladder Sep and they'll still stay on their Cellcep or mycophenolate. Here is your dosing. So you get 5 milligrams per kilogram and here's your dosing intervals. And then from there on, after that kind of loading phase, they only have to get it essentially monthly. And that helps with compliance. They come in, they get their infusion, they go home. And although we want them to take the oral medications, we know maybe they won't. So at least we got some coverage with the Bladder Sep even if they don't take their Cellcep and steroids. So we actually dose it based on their actual weight at the time of transplant, and you won't want to do that after transplant because your patients are probably going to be fluid overloaded immediately post-transplant. And we really don't make dose changes on Bladder Sep unless there's a greater than 10% change in their weight up or down. And the dose changes when you make a change has to be equivalent and divisible by 12.5. And that's just the vials that it comes in. So the thing for administration, you got to use silicone-free syringe, and the pharmacy should provide this to you guys. They should know this. And they should dilute it in normal saline to a total volume of 100, regardless of your dose. You need to give her 30 minutes, and you need to make sure you're using a 0.1 to 1.2 micron low protein filter set for this. You do not use butyrols because they contain silicone. The medication will bind to the silicone, and you will not be giving your patient medication. The nice thing about Bladder Sep, though, is it really doesn't have any, I can't think of any of them that haven't tolerated it. So you don't really have any bad drug interactions that require pre-medication. So literally they just come in and get this and go home. And then lastly, I know I'm probably a little bit running short on time here. I only have a few slides. I just wanted to mention there's many other meds. I was trying to hit up on the ones that were most commonly prescribed, but leflunomide is one that we use. It suppresses T and B cell production through inhibition of tyrosine kinase and a big word called dihydroorotate dehydrogenase. But they essentially, they work in combination with calcineurin inhibitors. So they go together, they increase the effects of calcineurin inhibitors. So you'll stop Cellcep to prescribe leflunomide. So that dosing regimen would be like a Tachylimus or Cyclosporine and leflunomide. So it exhibits effects on the herpes virus family too. So CMV, which is nice, which our patients commonly get. So it's kind of like a dual effect versus having to keep them on Valsite forever. You can see the adverse drug reactions. The main ones for leflunomide, I want you to keep into your mind. Abnormal LFTs, again, a liver thing. I have seen patients who we started on leflunomide and had their liver enzymes go really high. So we had to be very cautious. And then pancytopenia, again, are probably the most common things I see with leflunomide: liver problems and severe bone marrow suppression. Why would I give you leflunomide? It's most commonly used in place of Cellcep because of BK viremia. So BK is a virus that only transplant patients can get. It's a virus that's in the kidney and it stays at bay when you have normal immune system. The minute you immunosuppress somebody, BK virus becomes prevalent. BK is just the initials of the person who found the virus. So it doesn't really have a name. It's just the initials of the person. It's a virus. It can cause graft nephropathy. So it's terrible. Once they get BK or BK presents itself, it's very hard. When you have BK viremia, meaning BK is not just in the urine, but BK is crossed from your kidney urine into your kidney, into your bloodstream, and you've already tried to manipulate Cellcep down and you still can't get it to go away. Sometimes we just completely take them off Cellcep, put them on leflunomide because it's not as potent. Cellcep, again, remember, is one of the more potent ones. Still provides us good immunosuppression in tandem with calcineurin inhibitors. But most of the time when you put them on leflunomide, you can get better, your blood level of BK will reduce because your immune system is not as immunosuppressed. And then we actually you do have monitoring. There is what we call the leflunomide level, but it's teriflunomide, you can never say it. You do need to achieve a target of around 40 to 80, but I would say a lot of our patients honestly are kept around 100 to 110 on their levels. So in summary, the immune system is very complex. I could talk just about each little segment for a whole hour. So it's very complex, requiring various routes of immunosuppression. As you see, there's so many pathways on those T cells that we have to try to block. And we try to do all those different ways to maintain a stable graft function. At the same time, trying to prevent over immunosuppression, which causes bone marrow suppression. So it's a delicate balance between enough immunosuppression to prevent rejection versus too much leading to opportunistic infections or bone marrow suppression. And I really want the nephrology nurses to be knowledgeable about the doses that are on these slides. So if you see something that doesn't make sense per your patient's weight, just be alert, kind of, they should be on this dose per their weight or kind of the standard dosing. Really know about drug interactions, food interactions, be thinking about that all the time when you have these type of patients. especially if you have one and you're a floor nurse on the floor. Be very cautious about what the patient's eating because all these medications or other drugs can interact. So it's a nice time to kind of go through your patient's medications to see about drug interactions and or food interactions, because the residents, I promise you, won't be thinking about it. You have a lot of drug monitoring. You saw different trough levels, different AUC levels, all the different ways we monitor it and keep it in certain levels. And then all the adverse reactions, you can reference these slides later on and go back to them, be thinking about those adverse reactions for all the drugs and be knowledgeable about them so you can recognize them. So with that, I thank you for my time. I just have some references. These are all good references if you want them. So look them up, read them. That's where a lot of this information came from. And with that, I will open it up for any few questions that you guys have here. Let me get to that. Whoops. I don't see any there. I don't know if anybody, Celeste, are you there to see?
Yes, it doesn't look like we have any questions at this time.
All right. Well, if anybody, again, I'm on ANA, the SPN lead for pediatrics. So if you have a pediatric specific question, if you're struggling with a kidney transplant patient, any questions at all, just message me on ANA Connect or put a question on the forum. I'd be more than happy to give you references, advice, or try to find you any additional information you need.
Great. Thank you, everyone. Have a good day.
Thanks.